Καλησπέρα σας. Την Αναγόρευση σε επίτιμο διδάκτορα της Ιατρικής Σχολής του Πανεπιστημίου Αθηνών, του κ.John Puskas, θα προσφωνήσει ο πρίτανης του Εθνικού και Καποδιστριακού Πανεπιστημίου Αθηνών, καθηγητής Γεράσιμος Χιάσος.
Αξιότιμη κυρία Αντιπρίτανη, αξιότιμη κύριε Κοσμήτορα, κύριε Πρόεδρε, αγαπητές και αγαπητοί συνάδελφοι, πιστοί στην παράδοση του Ιδρύματός μας να αποδίδουμε τιμές σε προσωπικότητες που έχουν προσφέρει πολλαπλώς στην επιστήμη και στην κοινωνία, έχουμε σήμερα την ιδιαίτερη χαρά της απόδοσης της ύψης της τιμής, της ανακήρυξης σε επίτιμο διδάκτορα του Τμήματος Ιατρικής της Σχολής Επιστημών Υγείας του Εθνικού και Καποδιστριακού Πανεπιστημίου Αθηνών, του καθηγητή καρδιοχειρουργικής του Emory University της Ατλάντα, John Puskas, ενός διεθνώς αναγνωρισμένου καρδιοχειρουργού με σημαντικό κλινικό και ακαδημαϊκό έργο. Δεν θα ήταν υπερβολή να πούμε ότι ο καθηγητής Puskas ανήκει στις διακεκριμένες προσωπικότητες της ιατρικής επιστήμης που την επηρέασαν όσο λίγοι στο αντικείμενο της καρδιοχειρουργικής. Ο καθηγητής Puskas είναι ευρύτατα γνωστός για την προώθηση του πεδίου της στεφανιαίας χειρουργικής, ασχολούμενος ιδιαίτερα με την ολική αρτηριακή επαναιμάτωση και την αρτοστεφανία παράκαμψη σε επάλουσα καρδιά. Είναι συνεκδότης του πρώτου συγγράμματος αφιερωμένου αποκλειστικά στη χειρουργική των στεφανιαίων αρτηριών. Επιπλέον, είναι ο πρώτος που πραγματοποίησε ολικά θωρακοσκοπική αμφωτερόπλευρη χειρουργική κατάλυση προς απομόνωση των πνευμονικών φλεμμών για τη θεραπεία της κολπικής μαρμαριγής. Η συνεισφορά του στην έρευνα είναι πραγματικά εντυπωσιακή. Ο τιμόμενος υπήρξε ο κύριος ερευνητής σε σημαντικότατα ερευνητικά προγράμματα και έχει 15 διπλώματα ευρεσιτεχνίας. Έχει συγγράψει πάνω από 360 δημοσιεύσεις με 18.000 αναφορές, καθώς και 18 κεφάλαια σε έγκριτα καρδιοχειρουργικά συγγράμματα. Ο καθηγητής Puskas έχει διατελέσει πρόεδρος της International Society of Minimally Invasive Cardiothoracic Surgery και έχει αναλάβει σημαντικούς ρόλους σε πολλές αμερικάνικες και διεθνείς επιστημονικές οργανώσεις καρδιοχειρουργικής. Είναι ιδρυτής και πρόεδρος της International Society for Coronary Artery Surgery και του International Coronary Congress. Είναι εξάλλου αναγνωρισμένος για τη συντακτική του εργασία σε κορυφαία ιατρικά περιοδικά. Έχει παρουσιάσει περισσότερες από 350 διαλέξεις ως προσκεκλημένος ομιλητής σε εθνικά και διεθνή συνέδρια και έχει λάβει πολλές τιμητικές διακρίσεις. Η συνεργασία μεταξύ του Τμήματος Καρδιαγειακής Χειρουργικής του Mount Sinai, του οποίου διεύθυνε μέχρι πρόσφατα ο καθηγητής Puskas, και της Καρδιοχειρουργικής Κλινικής του Εθνικού και Καποδιστριακού Πανεπιστημίου Αθηνών, υπήρξε μακροχρόνια και πολύτιμη. Η σχέση αυτή αναμένεται να ενισχυθεί περαιτέρω από τη νέα του θέση ως καθηγητής καρδιοθωρακικής χειρουργικής στο Emory University και διευθυντής της καρδιοθωρακικής χειρουργικής στο Emory University Hospital της Ατλάντα, προσφέροντας μεγάλα ωφέλη για το επιστημονικό προσωπικό και τους φοιτητές μας. Professor Puskas, on behalf of the rectory authorities of the National Capodistrian University of Athens, I would like to express my sincere congratulations on the award of the title of Honorary Doctorate of the School of Medicine, in a way that truly honors your extraordinary achievements. It's a great honor for the academic community of the National Capodistrian University of Athens to welcome you to our institution. We are proud to acknowledge your contribution to science and deeply grateful to be inspired by your work. We wish you all the best in the progress of your scientific work and your future endeavors. Congratulations.
Παρουσίαση του έργου και της προσωπικότητας του τιμωμένου από τον καθηγητή του Τμήματος Ιατρικής του Πανεπιστημίου Αθηνών, κ. Δημήτριο Αγκουρά.
Κύριε Πρίτανη, θα μου επιτρέψετε να κάνω αυτή την προσφώνηση στα αγγλικά προς τιμήν του τιμωμένου. So, Honorable Rector of the National and Capodistrian University of Athens, respected Dean of the Faculty of Health Sciences and esteemed Dean of the Medical School, distinguished faculty members and fellow colleagues both from Greece and from the United States, my dear mentor, Dr. Wolf, ladies and gentlemen. It is with great joy and honor that I stand before you today to introduce our distinguished guest, Dr. John Daniel Puskas, a leading authority in cardiovascular surgery. For the past decade, Dr. Puskas has been a cornerstone of the Icahn School of Medicine at Mount Sinai in New York, where he served as professor of cardiovascular surgery and chairman of the department across Mount Sinai, Morningside, Downtown, and West hospitals. He also led as the director of surgical coronary revascularization for the Mount Sinai Health System. As of April 1st, about a couple of months ago, Dr. Puskas has embarked on a new chapter at Emory University, assuming the prestigious roles of Professor of Cardiothoracic Surgery and Chief of Cardiothoracic Surgery at Emory University Hospital. It's a big program with more than 5,000 pump cases a year in Atlanta, Georgia. An internationally acclaimed cardiac surgeon, Professor Puskas has made significant clinical and academic contributions, particularly in the field of coronary surgery. His pioneering work on total arterial revascularization and off-pump beating heart coronary bypass surgery has earned widespread recognition. Dr. Puskas' academic journey is nothing short of extraordinary, having graduated summa cum laude with a degree in biology from Princeton University, followed by a medical degree from Harvard Medical School. He expanded his knowledge with a master's degree of science in surgical science from the University of Toronto. His extensive training includes a general surgery internship and residency at Massachusetts General Hospital, a lung transplantation research fellowship at Toronto General Hospital under Professor Alexander Patterson, an advanced fellowship in tracheal surgery under Hermes Grillo, and a comprehensive residency and fellowship in cardiothoracic surgery at Emory University under Robert Guyton. As a highly proficient and dedicated operating surgeon, Dr. Puskas performs a wide range of modern cardiovascular surgical procedures, including not only all arterial, minimally invasive, robotic, hybrid, and off-pump coronary bypass grafting. His expertise in which has established him as a leading expert in the field, but also ablation for atrial fibrillation, mitral valve repair, valve sparing aortic root replacement, aortic dissection, and many, many others. Before his position in New York, he served in various positions at Emory University, where he excelled in all aspects of academic surgery. His commitment to improving care quality was evident during his tenure as the first quality officer in the Emory Division of Cardiothoracic Surgery, where he led experts multidisciplinary teams in fostering a culture of safety and continuous quality improvement, elevating the division star rating from 1 star in 2010 to 3 star in 2014, which is the highest 10%. Under his leadership, Mount Sinai Morningside has nearly tripled its clinical volume since January 2017, while maintaining outstanding quality outcomes as reflected in its consistent 3-star ratings. In 2022, Mount Sinai Morningside has also ranked number 16 nationally in the US for cardiology and cardiac surgery by US News & World Report. In the research domain, Dr. Puskas has been equally impressive, leading multi-million-dollar funded research programs. He established the Emory University Cardiothoracic Clinical Research Unit in 2005 and played a key role in founding the NIH Cardiothoracic Surgery Trials Network in 2007, serving on its steering committee since then. He has been the national and international principal investigator for 7 multi-center FDA trials in cardiac surgery and cardiology. At Mount Sinai Health System, he founded and directed the Cardiovascular Clinical Research Unit, creating a collaborative research environment that allowed clinical cardiologists and surgeons to enroll patients in multiple trials. His leadership in the first randomized controlled trial of hybrid coronary revascularization and his role as principal investigator on 8 National Heart, Lung, and Blood Institute funding research programs are testament to his research abilities. His innovative spirit is also evident in his 15 patents. Now, as an educator and mentor, Dr. Puskas has profoundly impacted hundreds of physicians, teaching medical students and graduate programs for many years. He initiated the non-ACGME track fellowship in advanced coronary surgery in 2019 at Mount Sinai St. Luke's Hospital, the first of its kind globally, demonstrating his commitment to advanced training and specialization in coronary surgery on an international level. He has also engaged in postgraduate extramural training programs, providing operative instruction and demonstrating off-pump CABG techniques to approximately 200 visiting surgeons and surgical team members, as well as mentoring attending surgeons at extramural centers sponsored by the Society of Thoracic Surgeons. Dr. Puskas has a significant editorial presence, contributing to leading medical journals such as the Lancet, Circulation, the Journal of the American College of Cardiology, and of course all the major medical journals of our specialty. His authorship of 378 publications with 19,500 citations and an H index of 68 in Scopus underscores his scholarly impact. He has also co-authored 18 chapters in esteemed cardiac surgery textbooks. Most importantly, Professor Puskas, in collaboration with Professor David Taggart from the University of Oxford, authored the first comprehensive textbook devoted entirely to the art and science of coronary bypass surgery. This extensive work, spanning 521 pages with 71 chapters, authored by over 100 renowned experts, covers every aspect of the surgical management of ischemic heart disease. It serves as a vital reference, offering in-depth insights into pathophysiology, evaluation, medical and interventional treatment, and emphasizing practical surgical techniques, thus becoming an indispensable guide for all adult cardiac surgeons and healthcare professionals involved in surgical coronary revascularization. A sought-after speaker, Dr. Puskas has delivered over 350 lectures at various national and international conferences and has been honored with numerous awards, including an honorary membership in the Society for Cardiothoracic Surgery in Great Britain and Ireland. He's an active member of many scientific societies, including the Society of Thoracic Surgeons, the American College of Surgeons, the American Association for Thoracic Surgery, the American College of Chest Physicians, and the American College of Cardiology. He has also served or is currently serving as president or member of numerous committees of major American and international cardiothoracic surgical societies, highlighting his professional dedication. Dr. Puskas has played a pivotal role in 2 significant societies. Firstly, the International Society for Minimal Invasive Cardiothoracic Surgery, the ISMICS, where he served as president in 2008 and 2009. This is a prestigious international scientific society whose 24th annual Congress is held in Athens these days. The second is the International Society for Coronary Artery Surgery, the ISCAS, which he founded and of which he is the current president. The mission of ISCAS is to advance surgical coronary revascularization and improve the care of patients with coronary artery disease worldwide. ISCAS offers a robust educational program featuring frequent, highly informative webinars, and serves as the parent organization for the International Coronary Congress, the ICC, which will hold its 10th meeting in London later this year. In my view, ISCAS is a clear testament to Dr. Puskas' visionary leadership. In addition to his professional achievements, Dr. Puskas is a passionate runner. However, even in this arena, there's always a way for him to demonstrate empathy for his patients. In 2021, he participated in the New York City Marathon alongside one of his patients who had previously suffered a cardiac arrest and undergone successful lower arterial coronary artery bypass grafting. To alleviate his patient's concerns about resuming training post-surgery, he offered to run with him, providing reassurance and support. And interestingly, their trainer was another of Dr. Puskas' CABG patients. While some might say that this is merely anecdotal, I think that it nicely illustrates the effectiveness and life-enhancing impact of total arterial revascularization. I personally hold Dr. Puskas in high regard, not only for his academic and other accomplishments, but also for his methodical thinking, for the evidence-based arguments and reasoning, and the overall clarity of his communication. In my view, these qualities establish him as a role model in academic cardiac surgery. Finally, I would like to emphasize the long-standing collaboration between the Department of Cardiothoracic Surgery at the Icahn School of Medicine at Mount Sinai and our university's Department of Cardiac Surgery. This partnership is rooted in the contributions of Emeritus Professor Anagnostopoulos, the inaugural chief of our cardiac surgery department, who also serves as a clinical professor of cardiac surgery at the Icahn School of Medicine. Additionally, Assistant Professor Tumboulis, a valued member of our department, was a researcher and clinical collaborator at Mount Sinai St. Luke's Hospital from 2003 to 2004. During his tenure there, he organized and statistically analyzed the adult cardiac surgery database, developed software for automatically retrieving mortality data from the Social Security Death Index, and established a comprehensive long-term follow-up database. This collaboration has resulted in 23 peer-reviewed publications in high-impact international cardiac surgery and cardiology journals. While this collaboration has historically been with the Icahn School of Medicine, we're now poised to build upon this legacy and establish a new bridge of collaboration with Emory University, where Dr. Puskas currently serves as professor and chief of cardiothoracic surgery. We eagerly anticipate the opportunities this new partnership will bring, furthering our shared commitment to excellence in all aspects of academic and clinical practice. Thank you very much.
Αναγόρευση του τιμωμένου. Ανάγνωση των κειμένων του ψηφίσματος του Τμήματος, της Αναγόρευσης και του διδακτορικού διπλώματος από τον πρόεδρο του Τμήματος Ιατρικής, καθηγητή Νικόλαο Αρκαδόπουλο.
Εθνικών και Καποδιστριακών Πανεπιστήμιων Αθηνών. Ψήφισμα του Τμήματος Ιατρικής της των Επιστημών της Υγείας Σχολής. Τύχη αγαθή. Πριτανεύοντος εν το Αθήνησιν Εθνικό και Καποδιστριακό Πανεπιστημίο Γερασίμου Δέλτα Σιάσου, κοσμητεύοντος εν των Επιστημών της Υγείας Σχολή Εμμανουήλ Α. Πικουλή και προεδρεύοντος εν το της Ιατρικής Τμήματι Νικολάου Φ. Αρκαδόπουλου, έδοξεν ομοφόνος το τμήματι John D. Puskas. Τα του ασκληπιού έργα μέγιστα επιστάμενων, την ιατρικήν επιστήμην έργοτε και συγγράμμαση προαγαγόντα και την εαυτού φιλανθρωπίαν πολλαχή επιδειξάμενων, προς δε τούτης εύρουν της έλυση διατελούντα, επενέσετε αυτόν και του της ιατρικής τμήματος διδάκτορα επίτιμον αναδείξε. Το δε ψήφισμα τόδε εις μεμβράν αναγράψε και τον του τμήματος πρόεδρον δημοσία εν τη αιθούση τη μεγάλη αναγνώντα και τα στιμάς ανυπώντα. Επιδούνε αυτό ή αν ημέρα η αναγόρευσης γέννηται καθά νενόμιστε. Εγένετο Αθήνηση μηνός Φεβρουαρίου 8 και 20 έτους 4 και 20 και της χιλιοστού από Χριστού γεννήσεως. Ο του της Ιατρικής Τμήματος Πρόεδρος Νικόλαος Φ. Αρκαδόπουλος. Αναγόρευσης. Επειδή περ το Τμήμα Ιατρικής της των Επιστημών της Υγείας Σχολής του Αθήνησιν Εθνικού και Καποδιστριακού Πανεπιστημίου John D. Puskas, άξιον απέφυνε του επιτίμου διδακτορικού αξιώματος, ιδέτης των Επιστημών της Υγείας Σχολή, τούτα παιδέξατο και ο πρίτανης της σχολής γνώμη επνεύει, διατάφτα εγώ, Νικόλαος Φ. Αρκαδόπουλος, καθηγητής της Γενικής Χειρουργικής, νύνδε του Τμήματος Ιατρικής Πρόεδρος, χρώμενος στη δυνάμει ειν παρά των Πανεπιστημιακών Νόμων και του Τμήματος Έχω Λαβών, John D. Puskas, επίτιμον διδάκτορα του Τμήματος Ιατρικής της των Επιστημών της Υγείας Σχολής του Αθήνης Συνεθνικού και Καποδιστριακού Πανεπιστημίου, δημοσία αναγορεύω, και πάσας αυτότας προνομίας, τα στο πανεπιστημιακό τούτο αξιώματι παρεπομένας απονέμω. Εγένετο Αθήνηση μηνός Μαΐου 1η και 30η έτους 4ου και 20ου και της χιλιοστού από Χριστού γεννήσεως. Ότου της Ιατρικής Τμήματος Πρόεδρος Νικόλαος Φιαρκαδόπουλος. Ελληνική Δημοκρατία. Πριτανεύοντος εν το Αθήνη Συνεθνικό και Καποδιστριακό Πανεπιστημίο, Γερασίμου Δέλτα Σιάσου, καθηγητού της Καρδιολογίας, Μοριακής Καρδιολογίας, εν των Επιστημών της Υγείας Σχολή, Κοσμητεύοντος, εν των Επιστημών της Υγείας Σχολή, Εμμανουήλ Α. Πικουλή, καθηγητού της Γενικής Χειρουργικής, προεδρεύοντος εν το της Ιατρικής Τμήματι, Νικολάου Φιαρκαδόπουλου, καθηγητού της Γενικής Χειρουργικής, John D. Puskas, από δόγματος ομοθήμου της των Επιστημών της Υγείας Σχολής, εις τους επιτίμους διδάκτορας εγκρίνομεν, μηνός Μαΐου 1η και 30η έτους 4ου και 20ου και της χιλιοστού από Χριστού γεννήσεως. Ο πρίτανης Γεράσιμος Δέλτα Σιάσος, ο κοσμήτορ Εμμανουήλ Α. Πικουλής, ο του της Ιατρικής Τμήματος Πρόεδρος Νικόλαος Φιαρκαδόπουλος.
Περιέρδηση του τιμωμένου με την τίβερνο της σχολής από τον κοσμήτορα της Σχολής Επιστημών Υγείας, καθηγητή Εμμανουήλ Πικουλή.
Ομιλία του τιμωμένου καθηγητή κ. John Puskas με τίτλο «The Evolution of Cardiac Surgery in the 21st Century».
It is difficult for me to express my gratitude to the Honorable Rector, the esteemed Deans, and the distinguished faculty of the National and Kapodistrian University of Athens for the honor of being here today and speaking to you and being with you here at this wonderful university. Dr. Anagouris asked that I would address the topic of the future of cardiac surgery because, as is the case for many medical professions, we are in flux, we are in change. And so I will attempt to do that today. These are my relevant financial disclosures. At first, I was very cautious and concerned about being given the role of becoming an oracle for cardiac surgery. I imagined that I didn't look much like this picture or painting by Eugene Delacroix. And indeed, there may be other people more suitable as oracles. These three giants of cardiothoracic surgery in Greece Constantine Anagnostopoulos, Demetrios Angoras, and Sotirios Papas are all here today and have had extraordinarily distinguished careers themselves. I cherish them all as good friends and treasured colleagues. But I am confident the future of cardiac surgery will be bright and that it will be built upon its Greek past. On the left, we see Asclepius, the son of Apollo, a Greek hero and god of medicine. In the center, Hippocrates, the mortal father of medicine, author of 70 tomes that comprise the Hippocratic corpus and the Hippocratic oath. On the right, Galen, the Greek who also worked in Rome and father of anatomy and physiology, whose concepts of the four humors dominated the thought of Western medicine for more than a millennium. The Hippocratic Oath, written circa 400 BC, enunciated and documented the principles of veracity, humility, beneficence, and non-maleficence. I won't attempt to pronounce the Greek. The Latin is primum non nocere, and the English, first do no harm. This is the line from the Hippocratic Oath that I remember and recite on a regular basis to my residents in the operating room. It remains the universal code of ethics for physicians and surgeons around the world. And I believe that Hippocrates' contributions to medicine can be viewed as a roadmap for the future of cardiac surgery in the 21st century, despite the fact that he was born in 460 BC into a hereditary order of priest-like physicians known as Asclepians, who believed that health and wellness were conferred by the gods. Hippocrates rejected purely divine causes of disease and also rejected the idea that medicine could only be practiced by those born into a certain class. He focused on a new, innovative, natural approach to medicine and sought a comprehensive understanding of patients' health based on scientific discipline and evidence-based knowledge derived from study of anatomy and observation of human pathophysiology. Another great man said that the best way to predict your future is to create it. So what would Hippocrates tell us to do as leaders of cardiac surgery? I believe he would tell us that cardiac surgery must evolve to be less invasive and morbid than it has been in the past, amplifying his concept of non-malevolence. It should maintain and expand its advantage and durability over percutaneous alternatives, emphasizing beneficence. And we should develop new surgical approaches to cardiac diseases that are not amenable to percutaneous solutions. That is to say, scientific discipline should advance evidence-based knowledge. So I'm going to take you through briefly 4 initiatives in coronary surgery that I hope will be an exemplar for the future of cardiac surgery. First, the rationale and techniques for all arterial, no aortic touch, off-pump bypass. Second, robotic-assisted minimally invasive hybrid coronary revascularization. Third, the new role of computed tomographic angiography and CT fractional flow reserve analysis in diagnosis and management of coronary artery disease. And finally, coronary endarterectomy, a new and frankly rather frightening operation for a new disease, that is to say, full metal jacket of coronary arteries. The first topic, all arterial revascularization. We know that multiple arterial grafts benefit patients in terms of longevity. This is the seminal paper from the Cleveland Clinic demonstrating that 2 internal mammary artery grafts led to longer survival for patients compared to patients who had only a single arterial graft. We're honored by the presence today of Mark Gilinov, the current chief at the Cleveland Clinic. At Emory, we took that step a little further and we asked ourselves, would double ITA grafting improve morbidity and mortality and provide a better longevity for patients who are diabetic? Because, of course, the older studies at the Cleveland Clinic were done at the time when we did very little surgery for diabetic patients. Now, 3/4 of our patients are diabetic. And this is a large, several thousand patients at Emory University divided into 4 risk-adjusted groups. You'll see in the top level that patients who did not have diabetes but did receive bilateral internal thoracic artery grafting lived the longest. Patients who had diabetes and received bilateral internal thoracic artery lived longer than those who did not have diabetes but only received a single ITA graft at the time of coronary bypass surgery. In essence, the surgeon providing the patient with double ITA grafting mitigated the impact on longevity of the presence or absence of diabetes, which is a remarkable finding. Why would that be? Well, it's because ITA grafts last longer. Here we see histopathological specimens in the top row of internal mammary arteries at 2, 6, and 12 years without any sort of pathophysiologic change, whereas the lower row, the saphenous vein grafts, at similar time intervals become plugged up over time with neointimal hyperplasia, and that leads to those grafts failing. Very recently, I had the privilege of participating in this interesting analysis of 1 million patients within the United States Society of Thoracic Surgeons database that demonstrated conclusively that multiple arterial grafting was associated with better 10-year survival than single arterial grafting. And that benefit was found in all patient subgroups, those with 2 or 3 vessel disease, those with little or dramatic left ventricular dysfunction, urgent and emergent patients, and on or off pump cases. Importantly, patients who were younger benefited the most, but even the elderly patients benefited for more than one arterial graft. The only group that did better with a single arterial graft were the massively obese patients with body mass index in excess of 40. But that same important analysis of the STS database revealed that only 12% of patients in 2019 received more than one arterial graft. And indeed, bilateral internal thoracic artery use represents about 6% now of all isolated primary bypass grafts operations in the United States. And this is despite the fact that we have known for many years that vein grafts fail at a predictable rate, which accelerates over time, and by 10 years, almost 50% of them are closed. Despite all of that, more than 80% of coronary bypass conduits used worldwide are still vein grafts. Importantly, the paper I just mentioned with the 1 million patients from the STS database had about an equal number of patients who received more than one arterial graft by virtue of having received 2 mammary artery grafts or 1 mammary graft and a radial artery graft. In other words, radial arteries are just about as good as internal mammary arteries in prolonging life. And this is another paper that I had the privilege of co-authoring with Mario Gaudino in the New England Journal, demonstrating that death and graft occlusion were less common in patients who received a radial artery graft in addition to a left internal thoracic artery graft with veins, rather than just veins alone. And that was because death, MI, and repeat revascularization was less common in the radial artery group at 5 years and again at 10. Nonetheless, radial artery graft in the United States is an infrequent activity. About 6% now of all patients receive a radial artery graft. Switching gears and looking at off-pump bypass, back in the late 1990s, I became very interested in avoiding the morbidity of the cardiopulmonary bypass machine and did the first randomized trial within our own patients of 200 unselected patients, randomizing them to have multivessel coronary bypass with or without the heart-lung machine. And we were able to demonstrate significant in-hospital benefits, including lower cardiac enzyme release, fewer transfusions, more rapid extubation, and shorter length of stay. We also documented similar graft patency, both in hospital and at 1-year follow-up. Quality of life was similar between groups, but the off-pump group cost less. We then analyzed 15,000 consecutive patients at Emory University who had off-pump or on-pump surgery. And you can see on the vertical axis observed mortality, and on the horizontal axis predicted mortality. Patients in the solid line are those who had on-pump surgery, and you can see the predictive algorithm works quite well. It's essentially a unity line. For patients with accelerating risk, you saw accelerating mortality in the on-pump group. But in the off-pump group, that only applied at the lower end of risk. After about 2.5% risk, the mortality curve flattened, and the gap between the on-pump and the off-pump mortality curves widened with increasing risk. In other words, the survival benefit of off-pump surgery appears when predicted risk is about 5%, and it accelerates above that point. We looked at this within the national database, almost 1 million patients, and found very similar curves. Despite that, off-pump bypass is about 15% of all isolated primary coronary surgery in America. Now, looking at Hippocrates' mandate that we should do no harm, primum non nocere. This is the one-year data from the Syntax trial that compared coronary bypass surgery and percutaneous intervention. At 1 year, the stroke rate in the coronary bypass group was 2.5%. In the PCI group, it was 0.6%, a striking benefit for PCI over CABG with respect to stroke. This is the FREEDOM trial. Diabetic patients randomized to coronary bypass surgery or percutaneous intervention with stents. Again, a twofold difference in risk of stroke in favor of PCI. Stroke is the Achilles heel of CABG. And that's because the ascending aorta may contain debris, atherosclerosis, calcification, and it's not always palpable. So when we cannulate the aorta or clamp it or manipulate it, we may dislodge that debris and send it up into the brain. We demonstrated that at Emory that the less you manipulate the aorta, the less likely is a stroke in your patient. And that includes on-pump cases where we can use a single clamp rather than multiple clamp applications. And off-pump and other techniques can be used to reduce stroke. You see the observed to expected ratio for stroke is least when we did not touch the ascending aorta at all. And the European guidelines recognize this, advocating that we should minimize manipulation of the ascending aorta. They also advocate an additional arterial graft, recommending the radial artery graft in preference to saphenous vein grafts, and bilateral mammary grafting should be considered in patients who can tolerate the risk of sternal wound healing problems. So the rationale for all arterial no aortic touch off-pump bypass is simple. We want to maximize the things that Hippocrates told us to maximize and minimize those that he told us to avoid. We want a better, longer-term patency, that's beneficence, and we want to minimize stroke risk and mortality risk at the time of surgery, non-maleficence. There are centers that have managed to do this. Alexander Albert in Germany has taken his entire department from a conventional on-pump CABG approach to a no aortic touch off-pump bypass approach and reduced the risk of early stroke by almost 90%. Here you can see in the red curve the early stroke risk plummeting to nearly zero as the rate of no aortic touch off-pump surgery in his department increased. I had the privilege of participating in this particular analysis of about 40,000 patients in 4 groups, comparing on-pump traditional CABG, off-pump CABG with a partial clamp on the ascending aorta, off-pump CABG with a heartstring device which avoids a clamp, and no touch aortic technique, the least invasive. This network meta-analysis used an interesting way of displaying data. You can see in the upper left for stroke, the no aortic touch technique was associated with a 78% reduction in stroke rate compared to the conventional CABG. You simply go down the vertical axis and across the horizontal to see the box that compares the 2 alternative therapies. The therapy that sits at the top of the pyramid is preferred. And you can see that for stroke and mortality, for renal failure, for atrial fibrillation, and for bleeding, the no aortic touch technique was the best of the 4 options. So it is recommended by the European guidelines, but it's very infrequently performed. I'm going to show you very briefly some surgical video of how we do it. Here we are with the left internal thoracic artery. We're marking the points for our intended targets. We're going to take a radial artery, which we've harvested endoscopically from the left arm. We're going to anastomose it to the side of the left internal mammary artery to create a composite conduit. This is a very standardized, controlled, set-piece kind of surgical procedure here. We do this exactly the same way every single time. It's a well-visualized and stabilized anastomosis that must have a perfect patency rate. We examine the graft, the anastomosis, and we test the flow in both limbs before proceeding with the operation. Here you'll see a right internal thoracic artery eye graft. I'm demonstrating the PDA there, the posterior descending artery, and the fact that this skeletonized right mammary will not reach it without some tension. So what do? We elongate it with a piece of a radial artery, again in a very standardized spatulated anastomosis. This one is an end-to-end rather than end-to-side anastomosis, and that creates a longer conduit that will easily reach to the PDA. It's done exactly the same way every time. Once again, we test the flow. Here we're demonstrating the anastomosis of that graft to the posterior descending artery in an off-pump approach using the octopus stabilizer under direct vision. I'm going to jump through some of these videos for the sake of time. The other anastomosis is for a we're going to jump through that. That's the acoustic part of the Doppler assessment of graft flow. Sorry for that. Here now we're anastomosing the left mammary to the LAD, and a diagonal branch is grafted with another radial artery side limb. This is my favorite operation, a no aortic touch off-pump bypass operation, which, as Dr. Anguras noted, we put on the front cover of our Oxford textbook. So that's avoiding maleficence, avoiding perioperative stroke. It's optimizing longer-term beneficence. There's another way that we'd like to try to reduce the invasiveness of surgery, and that's by using the robot and then combining it with coronary surgery. Combining the robot with coronary surgery and with percutaneous intervention. This is a hybrid approach where we use the Da Vinci robot and stents to accomplish multi-vessel bypass grafting to the LAD and stenting non-LAD targets. This patient was a patient refusing blood transfusion with multiple comorbidities. Those of you who are cardiologists or physicians will recognize the occlusion or stenosis in the proximal left anterior descending artery and in the mid-right coronary artery. We set up the room in such a way that the patient is on the table, the robot is over the patient, and the console for the robot is in the corner of the room away from the patient. We dock the robot, which is connected to trocars introduced into the left thorax. We use high-definition video and then move to the screen, to the console rather, which provides a 3D high-definition visual environment for the surgeon to manipulate these handles that drive the very fine tools inside the chest. In this case, we're using cautery to harvest the mammary artery as a pedicle. We're going to complete that harvest and transect it distally, and then prepare it for use as a bypass graft. The bypass graft itself will be done through a very small incision. You can see my fingertips show you that this is about a 4 centimeter incision. And here we're testing the flow in that bypass graft prior to closing the little incision between the ribs. Uh-oh. The benefit of the hybrid approach is really rather elegant. It combines what we hope will be the best parts of surgical minimally invasive therapy with the even less invasive attributes of percutaneous therapy. Thank you. Sure. The next stage of the hyperrevascularization is, in fact, the stenting of the right coronary artery after we document patency of the internal thoracic artery graft. And that completes the procedure. This patient went home in just 2 days and back to work in 2 weeks, so it has some real advantage for selected patients. But it can be done even less invasively. In total endoscopic coronary artery bypass grafting, or TCAB, we can harvest both mammary arteries and actually not do the small incision between the ribs, but complete the anastomosis directly through the trocars using the robot. Now, that is a technological trick and a technical trick that is much more difficult, and few surgeons are doing it. In fact, this series of videos is from Sam Balke and Gianluca Torgrossa at the University of Chicago, and they're using, in this case, a facilitated anastomotic device, the application of yet more technology to the construction of a coronary anastomosis. This device is being loaded with the harvested mammary artery, and then it's going to be deployed and automatically connected in a single function, a single moment in time. It'll be connected to that artery, which is being prepared and will be perforated, and then the anastomosis will be created in an instant once that anvil goes into the coronary artery and that mechanism is deployed. Again, in the interest of time, I'm going to skip through that. Interestingly, that device is no longer available in the market, and so we're having to hand sew these with the robot, which raises the stakes and makes the procedure more difficult. So I think that simulator training is going to be very important in the future, so that we can learn to do these devices without practicing on patients. If we think about the evolution of coronary bypass surgery, the highest form may well be the totally endoscopic off-pump robotic operation. But I'd like to see us just move the world forward to an off-pump all-arterial operation as a first step. It's important to note that less than 1.2% of patients worldwide are treated with a robotic-assisted coronary bypass. And part of that is because both that stabilizer device and the Flex-A anastomotic device are no longer available in the market. We need more technology to do the things that Hippocrates told us to do. Technology, in fact, has always been important to surgery. These are Athenian surgical instruments. I photographed them in the Acropolis Museum yesterday. These were literally used at the time that Hippocrates was practicing medicine here in Athens. But new technology is coming to cardiac surgery at a rapid pace. And I'm going to show you briefly one of the technologies that I think will be very disruptive in the near future. This is computed tomographic CAT scan imaging of the coronary arteries. In other words, coronary angiography without an invasive catheterization. And in this trial, we demonstrated that we could do coronary bypass surgery without the use of an invasive angiogram. So here is an invasive angiogram for these patients, and this is the first US patient enrolled in that trial. But this angiogram was not visible to the surgical team. All we saw was this, a CT angiogram, which lays out these lesions in the coronary arteries in a very different way. And then this, which is a computer-generated cartoon demonstrating flow reduction through those individual vessels. We used this, and this is the LAD view. Here's the left circumflex view. And you can see the cartoon demonstrating which vessels and branches had significant stenoses. And here is the right coronary view, again with the cartoon of the fractional flow reserve, telling us that the syntax score, which is for the non-physicians in the room, it's a quantitation of the extent of or complexity of coronary artery disease throughout the heart. This is a very high score. This is how we planned the surgery based on those images. And the computer gave us this algorithm predicting that outcomes would be much better for this patient with CABG instead of PCI because of the complexity of that disease. And I will make a prediction here. I'm not presuming to be our genuine oracle, But I will say that the hardware and software for computed tomographic CT angiogram is improving so quickly that I believe it will replace invasive coronary angiography as a primary diagnostic tool for patients with coronary artery disease. And this will fundamentally alter the gatekeeper role of the interventional cardiologist. This is on the left what we had planned to do, and in fact we were able to do exactly what we planned to do based on viewing only the CT angiogram. I think that in the future we will all routinely perform CABG based on non-invasive coronary angiography. This is at 30 days follow-up on the same patient, a repeated scan demonstrating patency of the grafts. And you can see the left internal thoracic artery graft coming down and touching down on the diagonal and the left anterior descending artery. The radial artery graft from the side of it, much as I showed you earlier, reconstructed, goes over to the obtuse marginal vessel. And the right internal mammary artery elongated with a piece of radial, as I showed you earlier, going to the posterior descending and over to the third obtuse marginal. At 1 month, the residual ungrafted syntax disease is trivial, 2 having been previously 66. And I'm going to conclude by showing you another procedure that we've become interested in and which is novel and driven by the present environment in which we work and where we're trying to serve patients with a new kind of problem, which is very diffuse coronary artery disease produced by diabetes and also full metal jacket vessels that are full of stents and cannot be further stented. But I'm going to start with a historical reference. This is a paper from '86 from Denton Cooley describing outcomes in almost 30,000 patients, about 10% of whom had coronary endarterectomy. And what he found was that their early mortality rates were higher, but those that left the hospital had a similar survival to patients who did not require endarterectomy. And for those of you who are unclear on what that means, here it is in our operating room. We're taking out a very long core of the inner 2 layers of the most important artery of the heart because it is so plugged up that we cannot manage to bypass it anywhere along its length. And this is the specimen that we extracted from the coronary artery. And then we spatulate this left anterior this left internal mammary artery and reconstruct the LAD with it. Now there's a recent paper looking at the entire STS database and found almost exactly what Dr. Cooley had found 25 years earlier. And I gather we see far because we stand on the shoulders of giants. But I'm going to show you in closing a case report of a single, our first patient for whom we did a left anterior descending stentectomy and endarterectomy. Here's the angiogram of the LAD. Our distinguished rector of the university, who is a cardiologist himself, will recognize that this has become a problematic situation for this patient and for the people taking care of him. And indeed, this man couldn't get to the toilet without angina. Here is his LAD. Here is the internal mammary harvested. Now we are cutting down on the anterior aspect of the LAD in order to remove a core of intima and media and stents while preserving the adventitia of the artery and leaving that intact. We begin the process by using this fine coronary dissector, taking some of the side branches to the diagonal, and then we're going to take that all the way up as far as we can go and also down as well. We're going to come down to the apex of the heart and perform a traction endarterectomy around the apex itself. And this will complete the core specimen from the LAD. Proximally, we need to transect the layers of stents, and I will attest to the strength of cobalt chromium, the alloy from which modern stents are made. It's extraordinarily difficult to cut. These are actually sternal wire cutters that are being used here because we had no other instruments that would go through the layers of stents. And you can see multiple layers of stents being trimmed there. So at this point, we have the adventitia of the LAD, the core and endarterectomy specimen, and the left internal mammary artery, each about 9 to 10 centimeters long. We spatulate the left internal mammary, and now we're suturing it to the LAD, which is a long and tedious process with such a long anastomosis. But basically, it's the same technique that we use in a regular anastomosis. It just takes about 10 times longer. Here we are completed, having basically reconstructed the LAD using the internal mammary artery. And then we test the flow, document good patency, and 6 months later, we test with angiogram to visualize the configuration and morphology of the neo-LAD, which has been rebuilt with internal mammary. And you see it's patent, and by 12 months, it's actually beginning to grow a little bit. It looks more uniform and more like a normal LAD. I'm not the first person to have been asked to predict the future of coronary artery surgery or cardiac surgery in general. Dr. Bruce Lytle and Michael Mack wrote this opinion piece almost 20 years ago. And they noted then that arterial grafting and off-pump surgery and smaller incision surgery has been adopted only by a minority of surgeons, and that we must anticipate further subspecialization within our field and embrace a commitment to technological research and development. Otherwise, we may become, as Eric Hoffer said, beautifully equipped to deal with a world that no longer exists. And very, very recently, just 2 weeks ago, Friedhelm Beiersdorf in Germany wrote this very interesting opinion piece on tctmd.com. The future of cardiothoracic surgery lies in innovation. I couldn't agree more. I hope that you will agree that Hippocrates would have told us that cardiac surgery must become less invasive, more beneficial, and more innovative in order to serve our patients globally. We should expect nothing more, nothing less than that for our patients, and I know that that's what he would expect of us. We will do that in partnership with all of our medical colleagues, especially our cardiology friends, because life is short and the art is long. Thank you so much for the honor of being here with you today.
Πέρας της εκδήλωσης. Σας ευχαριστούμε πολύ για την παρουσία σας.